I know. Sorry, I should have given you more heads up.
That's okay. So the topic that I'm presenting today is the session that I went to at the National Conference on Motivational Interviewing. The objectives are to review the origins of motivational interviewing, the characteristics and spirit of it, to understand the terms for motivational interviewing and the techniques and skills. So I have very limited formal training with motivational interviewing, just some, as with the national conference, a few conferences I've went to a session or two about it. So it was developed by William Miller and Stephen Rolnick as an initial counseling approach to alcohol use disorder. And they wrote a book in 1991 about this technique that they had been using, and then continued to use it and kind of broadened its use and came out with a second edition in 2003 relating to using it in healthcare settings, mental health, schools, correctional settings. And then they developed some new processes and came out with a new edition in 2013. So motivational interviewing is a sort of a collaborative approach with a patient to help a patient develop their own, to discover kind of what their own personal goals are and to increase their self-motivation to change and to achieve those goals. So it is empathetic, non-confrontational. Again, the goal is to strengthen the patient's own commitment and self-motivation to change and to support their self-efficacy. So it is not, you know, the physician or provider directing a patient and telling them what they think that they need to do. So it's not directive. You're not trying to play up that power differential, but actually kind of play it down, because the patient is their own, you know, they know the best about themselves. So you don't really use I statements. It's not a way of tricking patients into doing what you want them to do. And then they talk about this writing reflex, which is where it's very natural for a provider to want to go in or someone to want to go in and give advice and say, this is what I think you need to do. So it's about helping the patient discover what they need to do for themselves. So in the spirit of it, and that's what the developers really, they trained people, but they also talked about that it's a technique that needs to be used with a certain spirit behind it. And so it's a partnership, it's about acceptance and compassion. It's about evoking, again, the patient's own goals and motivations and plans. So it's about helping a patient grow. And then the other thing that the presenter in San Diego had said, it's more like a dance than wrestling. It's more like walking with someone than leading someone, which I think are good visuals for motivational interviewing. So ambivalence is a feeling, is a natural feeling that people have about behaviors, even behaviors that they may recognize that they need to change, like stopping using a substance, or, you know, cigarette smoking, or losing weight, or exercising more. But it's an obstacle to recovery. And so it's normal for a person with a substance use disorder to, you know, to recognize the dangers of using substances, but yet continue to use it. To want to stop, but also, you know, to want to continue, you know, using. And also to seek help, but then minimize the actual problems that their substance use is causing for them. So the technique is about trying to elicit change talk from a patient in regards to some behavior, some positive behavior change. And so it's about listening for statements that indicate that they're considering and committed to that behavior change, and reflecting that to them, reflecting that back to them to help increase their self-motivation. And sustained talk is kind of the opposite. It is statements that a patient makes sort of about continuing that negative behavior, or talking about reasons why they can't make the behavior change. So this mnemonic darn cat are the things that you're listening to in that change talk. And so you're listening for a desire, the patient saying, you know, statements that indicate that they want to change, ability, statements that indicate that they believe that they can change, that they have the ability to make the change, the reasons that it's important for them to change, statements that indicate why they feel they need to make that change. You're also listening for a commitment to making the change, and that statements indicating that they're ready to make that change. That's what the activation and taking steps is about. So how do you get at that change talk? You ask not closed-ended questions, but more open-ended questions that allow them to elaborate. You ask for examples. You ask about their life in a different time before they were engaging in that behavior, and helping them to reflect what was different about their life then as compared to now. So it is about developing that rapport, and in order to have an open, thorough conversation with a patient. So you have to get them to kind of let down their defenses by you know, not being judgmental with them, and asking those open-ended questions. And then it's, again, listening for that change talk, and reinforcing it. And then kind of focusing on what they determined that their goal was going to be in order to make that behavior change, where they feel like that they can start, what is a reasonable goal for them, something they feel like they can accomplish, and then developing a plan around that, a specific plan. So some of the skills are, again, asking open-ended questions, affirming what they're saying, you know, either, you know, when they're talking about what the possibilities are of, for example, of the things that they might change. And then reflecting back to them when, for example, when they're talking about why they feel that they need to make that change, making a statement back to them, helping them to reflect on that. And then a more complex reflection would be taking that one step further. So, you know, reflecting back to them about, you know, what they have said, but then kind of adding to it to help move them along, and then summarizing for them. And then you are, you know, with permission, going to inform them and advise them potentially of choices, of steps they may take, that kind of a thing. So again, it's based on that non-judgmental spirit, where the patient is, you're helping them realize what behavior change they want to make and what course they feel that they can take to make it. And so you're engaging them with these open-ended questions, affirmations, reflections, and then helping them to focus on a specific goal and develop a plan to reach that goal. At that point, you are giving some advice. You are working on eliciting that change talk. You can use the importance rulers and confidence rulers. So asking a person, you know, if they're interested in stopping smoking, for example, how important is it to them? And then when they give you a number, asking them, let's say they say that it's a 7, asking them why, it's a 7 instead of a 4. And then also judging their confidence in, by the same kinds of rulers, their confidence in reaching that goal. And then planning with them a specific plan that you can follow up soon to kind of check back with them and see how they're doing. So that's my understanding of motivational interviewing.
Wonderful, thank you. Does anybody have any questions or comments?
So have you integrated this into your practice, Dr. Green?
I have done a little bit of it, and we've actually integrated some of it into our, even into our electronic medical record system. So we have a section on tobacco cessation, and we've implanted those rulers in there and some, kinds of broad topics in there about what's worked before for people to quit smoking and that kind of a thing. I actually was recently at another conference and they discussed motivational interviewing in relation to diabetes and obesity and those kinds of things, those health behaviors as well.
There are actually some really great videos that are online that really that illustrate and in primary care settings that illustrate how to use motivational interviewing. And because it's one thing to kind of hear about it, and you did a great job. It's another thing to see it in action. So I encourage people to, and I can look some of this up and send those links if you want me to.
That's when I was reading about it. Also, they were talking about it's one thing to learn the terms and the skills, but really doing a like being observed, using it and critiqued on it is the most effective way, kind of to become nuanced at it.
Absolutely, and it does take practice, especially if we've been in settings where we're the expert and we're telling people how to, fix themselves, which is not always that effective if they don't agree with us. So it is this come alongside collaborative approach that is inherently non-judgmental. So I think in this population, it's particularly helpful to utilize it.
I think that as being primarily a primary care provider and, having those 15-minute appointments to deal with lots of complex issues, it's easy as a provider to say, I don't have time to do something like that. But I have in a couple of situations kind of tested those waters by saying, this is where your A1C is, well, what do you want to do about it, kind of a thing. What do you want to do, and try to use some of that. And it's interesting getting patients' responses.
Right, and then they have buy-in because it's their plan, not your plan. And does anyone else use motivational interviewing as part of their general ways of interacting with patients?
Yeah, we use it in our residency, and we train the residents in it. We could do much more of it, but that's kind of their approach to all this.
Great.
That's one of our primary interventions, particularly with the MARC program, the pregnancy program through obstetrics and gynecology. A lot of our group topics are focused on consciousness raising, trying to help people think through different reasons that they may be, in recovery after finding out that they're pregnant. Educating about community resources and kind of helping walk people through a change process, and eliciting change talk during group discussions.
I had never heard have you used the year 3, what would it take you to get a set to a 7, or what would it take? You do that?
So yeah, so that's kind of the readiness ruler or whatever people call it, and not saying, so because it elicits change talk to say, what would it take to get you to a 7, rather than why are you, like you had said, Dr. Ream, why are you a 7 versus a 3, which can elicit some change talk, but the idea of moving the arrow or the meter elicits often really strong change talk.
Yeah, I had not heard that before. So thank you, Dr. Green. Thank you, Laura. I definitely heard of MI, but not using that ruler. So.
And it's great that you guys incorporated it into your medical records, because that's very reinforcing for people to continue to use it.
All right. If anybody doesn't have, or if anybody has more questions, please let us know. We do have a couple more minutes if there are any other questions to bring up right now.
It can be about anything.
Yeah. Yep.
He's driving.
All righty, then I guess we'll call it for today. Thank you, Dr. Green, so much. You basically led this whole session. It was wonderful. Let's see, our next session is December 10th. And I do encourage everybody to come to that one, because the following one will be postponed because it falls on Christmas Eve. So obviously that will not be happening. So December 10th is our only one for that next month. And we need cases, always, of course. And then if there are any didactic topics you guys want to hear about, please let us know and we'll get those scheduled. All right. Everybody have a great day.
Thank you.
Thank you.
Thank you.